Good morning, or good afternoon, or good evening, class. So for this day, I'm going to talk about viral hepatitis serology. Um, so you will see in the next few slides that when you talk about serology of viral hepatitis, there are a lot of things that we actually check for. It might be confusing at first, but hopefully by the end of this lecture, it will be very easy for you to interpret what you see in the laboratory. Okay, so for this lecture, I'll be covering what we term hepatotrophic viruses. So what do you mean by hepatotrophic viruses? If you look at all the viruses out there are some viruses that can actually cause hepatitis without being hepatotrophic. So as the term implies, hepatotrophic means viruses that are living inside the hepatocytes and replicating inside the hepatocytes. So, for example, you can have, let's say, dengue. Dengue virus can also cause hepatitis. Your Epstein-Barr virus can also cause hepatitis. Your CMV virus can also cause viral hepatitis, but they are not hepatotrophic, meaning they are not living inside the hepatocyte. So, for this lecture, we'll be just tackling those viruses that are really living inside the liver and which causes damage in the process. Okay, so in general, there are two, general manifestations, but not of course not all viruses, not all hepatotrophic viruses will have chronic hepatitis, but all of them may present with acute hepatitis, meaning once you get the infection, you can develop symptoms of an acute infection. So I will be tackling the serology of acute hepatitis, viral hepatitis, um, prevention if there is a prevention, and then of course treatment. Now next, as I've mentioned, not all hepatotrophic viruses will cause chronic hepatitis. In general, when you say chronic viral hepatitis, it just means that the virus has been there in your liver for at least 6 months. So that's the basic timeline when you say chronic viral hepatitis. So we'll be tackling the serology again. Some unusual serologies, because you can have unusual serologies in these cases. How can you differentiate chronic viral hepatitis from acute viral hepatitis? And of course, indications for treatment. Now, this table is in your Harrison's. So basically, when you say hepatotrophic viruses, we have just 5 viruses. That is A, B, C, D, and E. There are other viruses like hepatitis G that has been suspected to cause human disease, but has not been really proven to cause, has not been proven to be consistently pathogenic for humans. So we'll be just concentrating on these 5 viruses, and you can see that in this table there are some generalizations that you can get. Okay, so I've boxed in the more important differences, and this is mainly due to the transmission. When you say hepatitis A and E, they are mainly fecal-oral transmission. Okay, while for B, C, and D, they don't really cause fecal-oral transmission. Now, for percutaneous, the virus hepatitis B, C, and D, all of them can cause percutaneous transmission. While for A and E, they seldom, if ever, cause percutaneous transmission. Okay. Now, another distinction is with regards to perinatal transmission. Now, for perinatal transmission, although B, C, and D can all cause perinatal transmission, it is highest in hepatitis B. Okay, and you will see later on. All right. Now, in terms of manifestations, you can see again, I've boxed in the more important differences. Primarily is progression to chronicity. If you can see, both hepatitis A and hepatitis E do not cause chronicity, unlike B, C, and D. they can all cause chronicity. They can all progress to chronicity. Okay, so there are some generalizations that you can already do in with regards to this table. Now, an exception, of course, is for hepatitis E. Um, Although it usually causes just acute infection, it can also progress to chronic infection in patients with immunocompromised state. So if you have HIV or patients who are undergoing chemotherapy or any other disease that can cause a decrease in your immune function, then uh, patients with hepatitis E can also progress to a chronic HEV infection, unlike hepatitis A, which will never cause chronic infection. Now, again, for fulminant hepatitis, when you say fulminant hepatitis, it basically means it's a severe form of hepatitis that causes hepatic encephalopathy. So that is the distinctive clinical manifestation of patients with fulminant hepatitis, and that is the presence of hepatic enceph. Now, for fulminant hepatitis, you can see that for among the viruses that can cause chronic infection, the highest will be hepatitis D. Now, later on, you will learn that hepatitis D cannot survive without hepatitis B, and it can be either superinfection or co-infection. Usually for fulminant hepatitis, due to hepatitis D, it happens in patients with superinfection rather than co-infection. And I will explain later on the section on hepatitis D why this is so. Now for hepatitis E, comparing it with hepatitis A, it also has a higher chance of producing fulminant hepatitis. Um, and this is highest in patients who are pregnant. If you have a pregnant patient, then there's a 20% chance actually of developing fulminant hepatitis E compared to a patient who is not pregnant or have no other comorbid factors. Okay. Now for prophylaxis, so basically this is vaccine, and you very well know that you probably have this. You probably have vaccine already for hepatitis A. You also probably have vaccine already for hepatitis B. Now for hepatitis D, once you vaccinate for hepatitis B, then you're vaccinated already against hepatitis D also, because D cannot survive without B. And then for hepatitis C, although there's vaccine available, is not readily available uh, in in the general public. So it's usually given for usually for the U.S. military. They give it before they travel to endemic countries. Okay, so when you talk about acute viral hepatitis, so as I've said, all hepatotrophic viruses can produce acute viral hepatitis. And because when you get the virus initially, then the virus can produce reactions in your body. Now, a common denominator for the hepatotrophic viruses is the virus itself really does not cause hepatocyte damage or injury. It's really the immune system's reaction against the virus that causes injury. Okay, so so acute viral hepatitis usually is preceded by an incubation period. So it depends on the virus how long the incubation period will be, and it's usually preceded by the jaundice is usually preceded by prodromal symptoms. So these are very constitutional symptoms. You can have fever, body malaise, anorexia. So these are very non-specific symptoms, but it usually precedes the onset of jaundice. Now, a very um, usual manifestations in terms of laboratory for acute viral hepatitis is that the ALT levels are usually very, very high. So here it says between 400 to 4,000. But in your book, if you look at your book in terms of differential diagnosis of patients with very high ALT, more than 1,000 IU per ml of ALT, then there are very few differential diagnoses. One is acute viral hepatitis, if you have an ALT of more than 1,000. The second one will be ischemic hepatitis, and the third one will be drug-induced hepatitis. Of course, there are exceptions. What exceptions will there be? For example, you can have autoimmune hepatitis. It can also have very high ALT levels if you have an acute flare of your autoimmune hepatitis. Other causes that can cause, other etiologies that can cause very high ALT levels, for example, will be a patient with cholelithiasis, for example. If you have a stone in the biliary duct, in your common bile duct, the acute obstruction there can lead to very high ALT levels. But of course, clinically, you will recognize this as well because these patients will have pain, biliary pain. Okay. Other possible causes, Wilson's disease can also cause very high ALT levels. So you can see here that there are, of course, other differential diagnosis for very, very high ALT levels. But initially, there are only three things that you have to look for: acute viral hepatitis, ischemic hepatitis, or drug-induced liver injury. Okay? Now, jaundice, of course, can appear after the prodromal symptoms. And of course, if you have acute viral hepatitis, you should always check for the liver function test. Now, the ALT and AST are not liver function tests. They are liver enzymes. So as the name implies, liver function tests for the function of the liver. So prothrombin time, your clotting factors, the components of your extrinsic coagulation cascade is usually produced by the liver. And that's why if you have decrease in liver function, then your prothrombin time increases. Your albumin, again, of course, is produced by the liver, and so it reflects the synthetic function of your liver. So albumin decreases in patients with acute liver failure as well, not only in patients with cirrhosis. Globulin usually increases in patients with portal hypertension, and we will discuss that later on in chronic viral hepatitis. And the platelet count, although it's not written in your book that it's a liver function test, also reflects your liver function. Why? Because your platelet uh, are the factor that stimulates your bone marrow to produce platelets. It's thrombopoietin, and your thrombopoietin is produced by your liver. So if you have liver dysfunction, then your platelet count also decreases. Initially because of decrease in thrombopoietin production. But later on, in patients with uh, chronic viral hepatitis, and maybe when you develop cirrhosis, you may develop hypersplenism, and then your platelet count can further decrease because of platelet sequestration. Okay? All right. So we move on to the first virus, and that is hepatitis A infection. As I've said, hepatitis A infection is usually a self-limited infection. It's acute viral hepatitis. It does not progress to chronic viral hepatitis A. So there's no such thing as chronic viral hepatitis A. Okay? So when you get a patient with hepatitis A infection, uh, the marker that initially will be increased, if you care to check for it, will be your fecal HAV because it's fecal oral route. So what happens if you ingest? So since it's fecal oral route, you usually get it from usually in food preparation where the water is contaminated or the actual food is contaminated because the person who's preparing it did not wash their hands when they're infected with hepatitis A. So once you ingest your hepatitis A, it gets absorbed into your bloodstreams. It goes to your liver. When it goes to your liver, it now replicates in the liver because it's a hepatotrophic virus. Once it replicates in the liver, the HAV RNA is now shed into your intestines. And that is why if you check your fecal HAV RNA, it will be positive. If you care to check for your serum HAV RNA, you will also find it, but it's not readily available. That test is not readily available. Even your fecal HAV RNA test is not readily available. Okay, so what do we do now in patients with suspected hepatitis A infection? We can check for your IgM anti-HAV because that is the first serologic marker that will increase. So usually at the second week of the disease, then your IgM anti-HAV will now be produced by your uh, immune system. Okay, so when the IgM anti-HAV increases, that's the time that you will also have the manifestations of liver injury. And ALT is a very good um, indirect marker of immune system destruction of your hepatocytes. As I've mentioned earlier, hepatotrophic viruses do not really cause direct liver injury, but it's the immune system's action against the virus that happens to live inside the hepatocytes that causes liver injury. Okay, so if the immune system now recognizes that there's hepatitis A infection, it will try to kill the hepatitis A virus. But since it's inside the liver, it will also destroy the hepatocytes. And the hepatocytes now will release your ALT, and then it will be followed by jaundice. Okay. Now, of course, as I've said, your your hepatitis A infection is self-limited. So once you have IgM anti-HAV, then your body will now start to produce your IgG anti-HAV, which is now the protective antibody against the virus. So if you have a patient with suspected to have acute viral hepatitis A, um, for you to be able to diagnose it, then you check for your IgM anti-HAV. Now, if you want to check if your patient has immunity against your hepatitis A virus, then you check for your IgG anti-HAV. Because once you develop immunity against hepatitis A, then you're immune for life. Whether it's from infection or from immunization, then you will be protected for life. Of course, over time, your IgM will now start to decrease and disappear. Okay? Excuse me. So, for hepatitis A infection, in endemic countries, developing countries such as ours, um, exposure to hepatitis A is very common. So childhood exposure is common, and then you can have actually subclinical infection and subsequent immunity in patients. So what I'm saying is um, an important concept I think that you have to remember for hepatotrophic viruses. Number one, I've mentioned earlier that if you have the cause of the liver injury is your immune system, right? So if you have an active immune system and it tries to kill the virus, there's symptoms, there's increase in ALT. Um, so for hepatitis A, you can see that uh, if you're exposed as a child, your immune system is also less mature than a patient who's an adult. Okay, so if you compare a child and an adult with hepatitis A infection, and I ask you, which one will be more likely to have symptoms? Will it be the patient with a mature immune system or an immature immune system? So as I've said, if you have a mature immune system, then the immune system can recognize the virus and try to kill the virus, but in the process, there's also liver injury. So if you compare a child and an adult with hepatitis A exposure, the child will be less likely to develop symptoms. Why? Because the immune system of a child is less mature, so the immune system will not be able to really recognize the virus too much, and that there will be not much liver injury that happens. But of course, eventually, since acute viral hepatitis A is self-limited, the immune system is still able to produce antibodies against the virus. In comparison, if you have an adult who happens to get hepatitis A, then the immune system is more mature, it's more robust, it can recognize the virus and destroy the virus um, uh, more actively. But at the same time, there's also a greater chance of liver injury and therefore clinical manifestations. So you will understand because of this principle that this first statement is true. In developing countries, we are very commonly exposed as a child to hepatitis A. So yung mga nag-iisaw dyan or fishball, you probably were exposed already to hepatitis A as a child. Um, for example, me, I already have hepatitis A antibodies, but I was never vaccinated. I never had you know, I never had self-limited jaundice when I was small. So some patients, when they're exposed as a child, they may just have maybe minor flu-like symptoms. Um, Unknowingly, they already had hepatitis A during that time, and they recovered from the hepatitis A infection. Okay, so that is why the second statement is also true, that when you are exposed as an adult, then you are more likely to be symptomatic. Okay. Again, hepatitis A, as with all acute hepatitis manifestations, is usually preceded by a prodrome of constitutional symptoms, followed by jaundice 1 to 2 weeks later. And then, of course, ALT levels will be very high. Okay, so prognosis for hepatitis A infection is complete recovery in most patients, but of course, there are some patients who are not as lucky, and then you can have fulminant hepatitis and maybe even liver failure requiring a liver transplant, but it's a minority of patients. There are two other unusual manifestations, and that is one is cholestatic hepatitis. This is basically jaundice that lasts for at least 10 weeks. I've had a patient with cholestatic hepatitis who had jaundice for 6 months. So it can be a protracted disease, but still, even if that happens, it doesn't still cause cirrhosis. So it just means that the patient has jaundice for a very long time. You can also have relapsing hepatitis, and this is basically a patient who has apparently recovered. Liver enzymes have gone down to normal. Symptoms have resolved. Your IgM anti-HAV has disappeared. But then after a few weeks, a few months, the patients um, develop the same symptoms again. Your IgM anti-HAV reappears, your ALT increases again, your jaundice reappears. So this is relapsing hepatitis. It can happen in 10 to 15% of patients, but still it doesn't cause cirrhosis. And usually patients after this second episode, they recover spontaneously, they recover fully. Okay, and the reason for the relapsing hepatitis is basically because the immune system was not able to clear the virus fully from the liver. Okay, all right. So we now move on to hepatitis B. Hepatitis B is a virus that can cause chronic hepatitis in comparison to your hepatitis A. Now, it's the only DNA virus. The rest of the hepatotrophic viruses are RNA viruses. As I've said, the hepatotrophic viruses are not cytopathic. They don't really cause direct liver injury, but it's the activity of the immune system that is responsible for liver injury. Okay? So if you remember the principle earlier that I've mentioned, if you have a mature immune system, the immune system is more able to fight off the virus, but in the process, there's more liver injury, right? Um, Now, for hepatitis B, this same principle also applies to the reason why patients uh, are more likely to develop chronicity depending on when they got the infection. For example, if you had perinatal transmission, you were infected at birth, your immune system is relatively immature, right? So your immune system is not able to fight off the virus, is really not able to recognize the presence of the virus. So, and that is the reason why if you get perinatal infection, the probability of chronicity is very high, 90%, because your immune system, tolerates the virus, allows the virus to just replicate inside the liver. Okay. In comparison, if you're an adult and you get hepatitis B, usually through horizontal transmission, either through needle stick injury or maybe through sexual means, your immune system is more mature. Okay, so if your immune system is more mature, it will be able to fight off the virus more effectively, and therefore your chances of chronicity is lower, okay, compared to a patient who is perinatally infected. However, having said that, adult patients who get hepatitis B will be more likely to be symptomatic when they get the acute infection compared to a patient who had the infection perinatally. The principle is the same because of the maturity of the immune system. Okay? All right. Now this cartoon is just to illustrate to you what happens inside your liver once you get the hepatitis B. So this is your hepatocyte. These are the viruses, the hepatitis B virus. As I mentioned, the cause of inflammation in the liver is really the immune system. So if you have immune destruction of your infected liver cells, it destroys the hepatocytes. Since your ALT and AST are located inside your hepatocytes, then your ALT and AST will be increased in your serum. Now, depends on when you got the virus and how effective the immune system is. Once the immune system is activated, there may be a decrease in the virus, and the patient may now enter the inactive care stage or recovery. So when you say recovery, the marker of um, hepatitis B positivity is going to be gone, and that is what we call the HBs antigen. Inactive care stage, and I will explain later on in the chronic stages. Okay, so suffice it to say, if you have immune system destruction of your hepatocyte along with your hepatitis B destruction, then the virus may decrease and then the patient may enter the recovery stage. However, not all patients will be as lucky. So some patients, even though there's immune system activation against the virus, there's still virus persistence. And if the virus is persistently there and the immune system is persistently acting against the virus, there will be chronic inflammation. Now, the natural reaction of our body to any injury is really to form a scar. So when you have inflammation, then you can have scar formation, fibrosis formation, right? The problem is, if you have chronic hepatitis B, then this becomes a vicious cycle because the virus is not killed off totally. Then there's still inflammation going on perpetually. And then your fibrosis deposition continues. And the end result will be what we call cirrhosis, wherein there's a lot of scar tissue in the liver and very little hepatocytes remaining, and it's replaced by scar tissue. Okay? And this is what we want to prevent in patients with chronic viral hepatitis B. We want to prevent scar formation so that the patients do not undergo cirrhosis. Okay? Now, this next cartoon is just to emphasize to you why hepatitis B is very hard to eradicate. So again, looking at the hepatocyte, this is cytoplasm, this is the nucleus, this is your hepatitis B virus. So once the hepatitis B enters the hepatocyte, it uncoats the surface covering. So the S antigen is removed, and what we now have the naked DNA of the virus. The problem with hepatitis B is that it also goes into the into your nucleus, and it forms what we call the cccDNA, or the close covalently circular DNA. Why is this important? The cccDNA is really responsible for hepatitis B being very hard to eradicate from your liver. Why? Because the cccDNA is really not recognized by your immune system. So it's very innocuous to your immune system. So, so that allows the hepatitis B to continue to replicate and infect other cells. So once you have the cccDNA, it serves as a template for your virus particles. So since the hepatitis B has a reverse transcriptase, it produces the RNA first, and then goes into the cytoplasm, and then you have the RNA-dependent polymerase and the DNA-dependent polymerase that converts your RNA into DNA. Okay, so basically you have the hepatitis B virus again here, and it can now go outside the cell. The problem with hepatitis B is that these viruses can again reinfect other cells, but it can also be recycled back into your DNA, into your nucleus, to form more cccDNA. So the cccDNA again is the one that is responsible for the hepatitis B being very hard to eradicate from your system. Okay, now as promised, I'll be discussing on the serology for hepatitis B. Now, if you look at the serology for hepatitis B, at first you might be, overwhelmed, and you might say, "Oh, there's a lot of things that I have to remember for hepatitis B," but really, it's not as complicated as you think. Um, I've highlighted in yellow the two most important parts of the serologic test for hepatitis B. And if there's two things that you have to remember after this lecture for hepatitis B, these are the two things in serology that you have to remember. Number one is the HBsAg. The HBs antigen um, is the marker that you have to look for to see if the patient is infected with hepatitis B or not. Meaning, if your HBs antigen is positive, there's no question about it. The patient is infected. Okay? Regardless of what you see in the rest of the serology, if your HBs antigen is positive, then the patient is infected. Now, the anti-HBs, anti-hepatitis B surface antigen antibody, um, is the protective antibody against hepatitis B. Okay? Um, a positive result means that you're protected, except if you have a positive HBs antigen as well. Okay? Because there are also unusual serologies for hepatitis B. So you can sometimes have a positive HBs antigen with anti-HBs. And then that may confuse you because you know that HBs antigen is a marker of infection, but anti-HBs is a protective antibody, right? So in these cases, you believe the HBs antigen over the anti-HBs, because the anti-HBs in these cases where the S antigen is positive is not a protective antibody. Um, it's it's an antibody that is directed against a different serotype of the hepatitis B surface antigen. And you can read more in your book as to what the serotype means. Okay, so but basically, two things that you have to remember: S antigen positivity, you're infected. Anti-HBs positivity, you are protected, except if you also have a positive HBs antigen. Now, the other test like HB antigen, anti-HB, and HBV DNA, are taken together to determine the the stage of the chronic infection of the patient. And I'll show you a graph, a figure later on that will explain this more fully. The SGPT or the ALT is also being used to determine the stage of the chronic infection. Now, the bottom two tests are also very important, okay? The anti-HBC or the anti-HB core antigen, okay? The anti-HBC IgG usually means exposure. So a passive anti-HBC IgG means that the patient was exposed to hepatitis B. What use is this in our patients in practical means? The practical application of this is that sometimes you can have a patient with anti-HBS with negative HBS antigen um, with an anti-HBC IgG positivity. What does that mean? That really tells you whether the patient developed anti-HBS due to vaccination or due to exposure. Because you have to remember, you can never have anti-HBS in your system without exposure to your HBS antigen. Okay? So the exposure to HBS antigen may be from uh, a natural infection or from the vaccine, because our vaccine is recombinant HBS antigen. So it's basically, you know, they produce the antigen from a chicken embryo. So basically, it's still exposure to S antigen. So the anti-HBC IgG here really is to help you uh, distinguish between the antibody levels of the patient being from vaccination or from exposure. Okay. Now the anti-HBC IgM, in comparison, usually denotes either you have acute infection or, more commonly in our country, is really a patient with chronic infection that happens to have a flare of their hepatitis. A flare means basically there's an increase in your ALT levels by more than 5 times the upper limit of normal. Okay, so again, the anti-HBC IgM may be acute infection or maybe a flare of chronic hepatitis B, which is actually more common in our case. Now, when you look at serology of patients with hepatitis B, there are two things that can happen. It really depends on when you got the infection. So, as I've mentioned earlier, if you get the infection as a child, perinatal transmission, then the probability of resolution, meaning yeah, your immune system is able to fight off the virus, is low. But if you get the infection as an adult, then your immune system is very active. There's a higher chance of your immune system clearing the virus. So this figure is really pertaining most likely to a patient who was exposed as an adult, because there's acute hepatitis B with resolution of your hepatitis B. So what happens first? When you get exposed to hepatitis B, usually as an adult, maybe horizontal transmission from needle stick injury, from sexual transmission, um, the first screening test that we usually do is to get the HBS antigen. Okay, of course, actually, in the acute exposure stage, the first thing that will be positive will be your HBV DNA. Okay, but of course we don't screen with HBV DNA because it's very expensive. The results doesn't come out very fast. So we check for acute infection with HBS AG. So your HBS antigen will be the first one that will be positive, and then as I've said, your IgM anti-HBC will now be positive because your immune system will now start to produce antibodies against the virus. Okay, so after the IgM anti-HBC, since this is a patient with resolution, what happens now is your IgM anti-HBC will now disappear and your IgG anti-HBC will now appear. And then, of course, this is a patient with resolution. Your S antigen will now start to decrease along with your HBV DNA. And then, since your viral count is decreasing, then the patient will now develop your protective antibody, the anti-HBs. Okay. Now, in your book, it also mentions what we call the window phase. So, window phase is basically this area where your HBs antigen is decreasing until it's gone, but your body hasn't been able to develop anti-HBs yet. And the only marker that will be positive in these patients will be your anti-HBC, or in some cases even your anti-HBe. Okay, so that's what we call the window phase. Now, the typical serologic course for a patient now with chronic infection, and this is very common in our country because we are endemic, and perinatal transmission will be the most common mode of transmission, is for patients who have the hepatitis B for a very, very long time. So the definition of chronic hepatitis B infection is that your HBs antigen is positive for at least 6 months. Okay, so in chronic infection, since this is chronic, the S antigen remains positive. Okay, again, after the acute infection, your IgM anti-HBC disappears, and then you will now have your anti-HBC IgG. But you will not develop your anti-HBs except in patients with unusual serology. Okay, now the HB antigen, I will explain further on in the next slide, is really just a marker of the amount of replication that the virus is doing in the body. Okay, so it depends on the chronicity, whether your HB antigen will be positive or not. Now, as I mentioned, your IgM anti-HBC can also reappear in patients with chronic infection. So you can have IgM anti-HBC again in patients with flares where the ALT increases, usually to more than 5 times the upper limit of normal, and you can have a reappearance of your IgM anti-HBC. Okay, now this next figure is really to show you the differences in the stage of a chronic infection. Um, the first stage is really what we call the immune tolerance phase. So immune tolerance, as the name implies, means that the virus is tolerating the presence of the virus. So what happens if the immune system is not active against the virus? Then your SGPT, shown in the yellow line, is normal because the immune system is not destroying the hepatocytes. So in the immune tolerance phase, the HB antigen is positive, your DNA, HBV DNA levels are very high, but your ALT is normal because the immune system is not destroying the hepatocyte. Now, there will come a time that the patient's immune system will be will now be awakened against the virus. And for patients with perinatal infection, this usually happens between the second to fourth decade of their lives, where the immune system is now awakening against the virus. It will now try to kill off the virus inside the hepatocytes. So what happens is that your ALT increases because there's immune system destruction of your hepatocytes. So in this phase, or what we call nowadays HB antigen positive chronic hepatitis, your your HB antigen remains positive. Your DNA may remain very, very high levels, but the main difference between these two phases is that your ALT is increased in the immune clearance phase. Okay? In your book, it says that the HB antigen really separates patients into a relatively replicative stage and a relatively non-replicative stage. Um, Basically, the reason for that is that in patients with HBe antigen positive status, the virus is usually um, replicating very rapidly. While in patients with HBe antigen negative status, the virus is not as as robust in terms of replication. Okay, I'm saying usually because in some cases you can also have very high viral replication in patients with HB antigen negative status. Okay, so what happens next? What happens next is that after the immune system is activated against the virus, in about 60%, 70% of patients, the immune system is successful in killing of the virus. So the DNA starts to decrease, and since there's decrease in your viral levels, the immune system destruction of your hepatocytes also decreases. And another thing that happens here is there is what we call HBe antigen seroconversion. Okay, seroconversion. So what happens there is that your HB antigen from positive status becomes negative. Your anti-HBe, which was negative initially, becomes positive. So when that happens, we now have what we call the inactive carrier stage, meaning the patient is still infected because the HBs antigen will still be positive in these patients. But the HB antigen is negative already. Your DNA levels are very low, less than 2000 IU, and then your ALT is normal. Okay? Now, of course, the story doesn't end here because in a few proportion of patients, about 20% chance that these patients may actually have a reactivation of their viral replication. So in these patients, even though the HB antigen remains negative, which in your book says they're relatively non-replicative stage, it can still be that patients may have an increase again in your DNA levels and an increase in your ALT levels. And this is what we call the HB antigen negative chronic hepatitis. Okay, so these patients, even though they are e antigen negative, there can still be liver injury that happens. Okay, now in the immune tolerance phase and the inactive care stage, the probability of developing cirrhosis, the probability of developing very high inflammation levels in the liver are very low. So that's why in these phases of the chronic infection, usually treatment is not indicated. Okay. Now, for the immune clearance phase and reactivation stage, it's a different story because these patients have very high chances of developing cirrhosis and very high chances of developing flares of their viral hepatitis. And this will lead to a lot of inflammation and a lot of injury. And that is why these patients are usually the ones who need treatment because you don't want them to progress to liver cirrhosis. Okay? Now, of course, not all patients will have a very clean graph like this, that if you have, inactive care stage, the graph will be like this. The ALT is always normal, the DNA is always normal. Actually present like this, where, um, you know, the DNA levels, the ALT levels may be fluctuating. So for example, for the reactivation stage, if you get a patient, if you happen to see the patient at this point in time, you may falsely conclude that the patient is in the inactive care stage because the ALT is normal, DNA is low. But if you follow them serially, it may actually be fluctuating. So the moral lesson really is for chronic hepatitis B especially, you have to have serial monitoring. You don't forget to monitor your patients because these patients may actually need treatment. Okay? Now, I've mentioned in passing the HB antigen. So there are several reasons for the loss of your HB antigen, which I've said mentioned is a marker of very high replication in the patient. So it may be due to HB antigen seroconversion. So it may be spontaneous, as I've shown you in the previous figure, where after the immune clearance phase, if the immune system is successful, then the patient may enter the inactive carrier stage. And during that process, you also develop HB antigen seroconversion. Okay, so your E antigen from positive status becomes negative, your anti-HB becomes positive from a negative status. So these two are usually, you know, inversely related. If you have HB antigen positive status, your anti-HB is usually negative, and vice versa. Okay, usually there are some cases where it may be both positive or it may be both negative, which we will discuss later on. Now, the the loss of the HB antigen may also be due to mutations inside the virus. It may be due to a pre-core mutation or core promoter mutation. If you have pre-core mutation, and then that will lead to absence of HB antigen production. While if it's core promoter mutation, there's a decrease in your HB antigen production. Now, there are also unusual Hep B serology out there. And as I've mentioned in detail earlier, you can have HBs antigen status, reactivity, and also anti-HBs reactivity. You can have an isolated anti-HBC reactivity, meaning you have anti-HBC, but then the rest of your other serologic markers are negative. You can also have HBs antigen non-reactive but DNA positivity. And finally, you can have HB antigen reactive and anti-HBe reactivity. We'll tackle one by one. Okay, so as I mentioned, S antigen and anti-HBs can coexist. But again, what will you believe if both of these markers are positive? You believe the S antigen. So the HBs antigen trumps the anti-HBs positivity. Okay, because the anti-HBs here is not protective. It's directed against a different Hep B serotype. It may also be due to a mutation in the virus. So sometimes you can have vaccine escape mutants or host immune pressure, especially in post-transplantation patients, where the virus, because of the immune pressure, develops mutation where they do not produce the 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 S antigen, and but they are still positive for hepatitis B. Okay. So what else? You can have isolated anti-HBC reactivity in countries where hepatitis B is not very common. Then usually it might be a false positive result, especially in patients with other autoimmune diseases. Um, so it can be a false positive result, but in endemic countries such as ours, then usually it's because of a remote Hep B infection. So the patient was exposed before, develop antibodies, resolve the hepatitis B, but eventually, since the anti-HBs can also wane over time, so the anti-HBs becomes negative, but the anti-HBC remains positive in these patients. So it may be a remote Hep B infection. Now, there are also cases where you have HBs antigen non-reactivity but DNA positivity. Usually it means that the patient has what we call occult Hep B infection. So these are patients where all the other serologic markers are negative, but the DNA is only the one that is positive in the serum. Okay. Now, in some patients, it can also mean that the patient has resolved the hepatitis B, so meaning the S antigen has become negative. But since, as I mentioned earlier in one of the slides, there's the presence of the cccDNA. So the cccDNA, even though patients recover from hepatitis B, the cccDNA remains in the hepatocytes. It can these uh, templates for the virus can sometimes still produce DNA levels. So you can have low titer HBV DNA levels even in patients with resolved hepatitis B status. Now, the HB antigen positive status is really important in determining the endpoint of treatment. And we will not discuss very in detail with regards to this, but basically the same thing with HBs antigen. For HB antigen, you believe the HB antigen over the anti-HBe. So if both are positive, then the patient should be treated as an HB antigen positive patient. Okay, now if you look at your book, you can see that um, this is actually taken from your book in terms of uh, who are the patients who need treatment. So in general, if you look at this slide, you might be overwhelmed again because there are a lot of things to remember. But basically, you have to understand the principles of why we're treating patients with hepatitis B. Okay, number one, um, we want to prevent patients from developing cirrhosis, right? So who are the patients who are more likely to develop cirrhosis? These are patients with inflammation. These are patients with active immune destruction of the hepatocytes. What is the marker of inflammation? Indirect marker of inflammation in the liver? That is ALT levels, right? So if your ALT levels are higher, then that means you have more inflammation in the liver, and these are the patients that you want to treat earlier. So if you just look at the HB antigen positive patients in this part of the table, if you have high ALT levels, then patients may has probably in the immune clearance phase, and these are patients who need to be treated compared to patients with lower ALT levels, right? If you have low ALT levels, then maybe these patients are not in the immune clearance phase. Then we just need to monitor these patients. Now, another principle that you have to remember is that the treatment is needed more for patients with more severe liver disease. So, a patient with cirrhosis um, is different from a patient with just chronic hepatitis. So, if you have compensated cirrhosis, meaning there's no um, clinical manifestations of decompensation like ascites, variceal bleeding yet, um, compared to a patient with decompensated cirrhosis patients are worse off than patients with compensated cirrhosis. So if you look at the criteria for treatment, patients with more severe liver injury have lower thresholds for treatment. For example, decompensated liver cirrhosis. Um, if you have detectable DNA, regardless of the level, even if you have very low level DNA, and regardless of your ALT levels, you have to treat because the patients are decompensated. They have very poor liver function. And this is different from patients with compensated liver cirrhosis. If the patient has compensated liver cirrhosis, then it's different from patients with liver dysfunction. So if you have a compensated liver cirrhotic patient um, and very low viral levels, if the ALT is high, then you consider treatment. I will start treatment already. In patients with higher DNA levels, regardless of your ALT levels, then you have to treat. So this is in contrast to your chronic viral hepatitis, where you really need a high ALT levels before you start treatment. So if you look at the trend here in terms of who are the patients who need treatment, then the worse the liver function, then the lower your threshold will be in terms of starting treatment. Okay. Now again, um, you also have to divide your patients into HB antigen positive and HB antigen negative patients. The main difference, again, uh, with regards to positive and negative status is that for HB antigen negative patients, for chronic hepatitis, the DNA levels, um, the DNA levels that are needed in order to consider treatment are lower compared to HB antigen positive patients. Okay, but for cirrhosis, whether compensated or decompensated, they're basically the same. Now, treatment options, of course, in your book, it still discusses about interferon, peg interferon, and your oral treatments. Nowadays, peg interferon is only of historical means because it's not readily available anymore. Um, and what is available to us are oral drugs. And these are lamivudine, adefovir, entecavir, tenofovir. But you only have to remember these two because lamivudine should not be used anymore, adefovir should not be used anymore because of the presence of a high rate of resistance compared to entecavir and tenofovir. Okay? Okay, prophylaxis. Of course, in patients who are born to HBs antigen positive mothers, then the baby should be given both um, passive and active immunization. Okay, so you have to give the immunoglobulin immediately after birth and your Hep B vaccine immediately after birth as well. Now, nowadays we also know that mothers who have very high DNA levels are also more likely to have vaccine failures for their babies. Meaning, even if you give the vaccine, the babies may still be infected. So that's why in mothers who have very high levels of the HBV DNA in the third trimester, they have to be given tenofovir to bring down the virus levels so that the probability of vaccine failure is also lower. Okay. Now for adult patients, post-exposure prophylaxis, you have to give both the vaccine as well as your immunoglobulin to prevent um, acute viral hepatitis B. Okay, all right. So now we proceed with hepatitis D. And as I mentioned earlier, hepatitis D cannot survive without hepatitis B. It is dependent on Hep B for replication and protein expression because it uses the HBs antigen as its outer envelope. Okay, so um, as I've mentioned, it can be a co-infection or superinfection. Now, in an important principle for hepatitis D is that the duration of the hepatitis D infection is really determined by your hepatitis B infection duration. It cannot really outlast it. So, meaning, if you get an adult who happens to have co-infection, for example, of hepatitis B and hepatitis D, so they were infected with both B and D as an adult, what is the probability of chronicity for hepatitis D? Will it be high? Will it be low? For hepatitis D, again, if you get hepatitis B as an adult, what is the probability that you will resolve? Very high, right? Because the immune system is active against the virus, it will now destroy the virus. Um, and if you happen to be co-infected, the D will not it will not outlast your hepatitis B. So the probability of chronicity for hepatitis D, if it's co-infection in an adult patient, is very low. Okay. Um, there's a statement here that says, although hepatitis D does not increase chronicity of hepatitis B, it may increase liver disease severity. This is very true, especially for patients who are super infected, meaning the patient already has hepatitis B for a very long time and then happens to get hepatitis D through exposure as an adult. Why is it that patient may have a more severe liver disease in this case? This is because if you have chronic hepatitis B already, you may already have cirrhosis. You may already have significant liver injury. And then when you have hepatitis D on top of the significant liver injury from your hepatitis B, then you may have a more severe manifestation of your liver disease. Okay? Now, hepatitis D, fortunately, is not very common in our country. It's more endemic in the Mediterranean country. Now, this is a typical serology of a patient with co-infection. As I've mentioned, usually co-infection happens in adult patients. Usually, this is horizontal means. So what happens again? For co-infection, if it's adult, what happens to your hepatitis B? It's self-limited usually. The patient will recover majority of the time from hepatitis B infection. So your HBs antigen here will be short-lived. It will stop, and then the patient will now develop anti-HBs because this is adult acquired. Now, what happens with your hepatitis D? The first marker that will be positive is your HDV RNA. And then, of course, you can have your IgM anti-HDV. Those are the first markers that will tell you that the patient also has hepatitis D. Okay. Now, since this is self-limited infection, your hepatitis D anti-HDV IgM decreases. And what will now appear is your IgG anti-HDV. Okay. Since this is self-limited, the HDV RNA will also be stopped in terms of production by your inside your hepatocytes there will be stop in the production, and then the patient will have resolved hepatitis D. Okay, so both your hepatitis B and hepatitis D will be resolved. Now, what is the marker then of resolution? The marker of resolution of hepatitis D infection is your HDV RNA because the HDV RNA resolves. Now, your IgG anti-HDV, although it's present after resolution of your hepatitis D, over time also becomes negative. Okay, if you resolve your hepatitis D. So your anti-HDV here is not a protective antibody. It's just a marker of exposure to hepatitis D. Okay, unlike your anti-HBs, which is a protective antibody. Okay, what happens now with superinfection? As I've mentioned, superinfection, hepatitis D superinfection happens if you already have a chronic exposure to hepatitis B. So your HBs antigen here is there for a very long time because this is a patient with chronic hepatitis B who happens to be infected with hepatitis D after getting hepatitis B. So this is superinfection. So your HDV RNA, again, will be the first marker that will be positive in patients with hepatitis D infection. And your IgM anti-HDV will initially be positive and decrease, and then it will now be replaced by your IgG anti-HDV. Okay? But since, as I've mentioned, the marker of resolution of hepatitis D is the HDV RNA. Since this patient will not resolve the hepatitis D infection, the HDV RNA will also be positive for life as long as the patient is also infected with both viruses. Okay, so this is the typical serologic course for a patient with hepatitis D superinfection on top of a patient with chronic hepatitis B. Okay. So now we move on to hepatitis C. So hepatitis C, in comparison to hepatitis C, although both of them causes chronicity, there's really no distinction between whether you get it as a child or get it as an adult, whether you proceed with chronicity or not. In hepatitis C, in general, chronicity happens in the majority of patients. 85% of patients, 85% of patients with acute hepatitis C will proceed with chronicity. The main difference, the main reason why this happens is that for hepatitis C, the virus mutates very rapidly. So once the patient is exposed to hepatitis C, the immune system is not able to really mount a very effective response against the virus because the virus mutates very rapidly. And that is why it escapes immune system destruction and the patient proceeds to chronicity most of the time. Now, there are 6 general genotypes, 1 to 6. The most common worldwide is genotype 1. Um, of course, 2 and 3 are also are common, but the most common is still genotype 1. Okay, it's common in IV drug users. It's also common in patients who were transfused before the year 1996, 1997, when hepatitis C was still not routinely checked in blood banks. Now, for the minority of patients who happens to resolve the infection 15% of the time, this is what happens in terms of the serology. So the first marker that you will see is your HCV RNA. So once you're infected, the HCV RNA increases. And since these patients resolve the hepatitis C, what happens is the HCV RNA becomes negative over time because the immune system is successful in clearing the virus. Okay, so once exposed to the virus, the ALT starts to increase, and then since you have resolution of the virus, the ALT also decreases to normal levels later on. Now, the anti-HCV here starts to appear later on, usually about 8 weeks of the disease, 8 to 10 weeks of the disease, the anti-HCV will now be produced by the body, and that will be a marker of exposure to hepatitis C. Now, what is important for hepatitis C is the anti-HCV is not a protective antibody. Although in this graph figure, you might think, okay, since you have resolution, the anti-HCV is positive, you might falsely conclude that the anti-HCV here is protective because your HCV RNA is negative, the patient now has antibodies. But you will see later on in the chronic hepatitis C figure that this is really not a protective antibody. The marker of resolution for hepatitis C is really your HCV RNA. If your HCV RNA is negative, then the patient has resolved their hepatitis C. Now, for chronic hepatitis C, what happens here is that your HCV RNA remains positive for more than 6 months. Okay, so again, your HCV RNA is positive, and that will tell you that the patient is still infected with hepatitis C. Now, I told you earlier that your anti-HCV is not a protective antibody, and this is the reason why. You can see here that this patient, although the patient has chronic hepatitis C, HCV RNA is still positive, the anti-HCV remains positive, even though you have the virus in the body. Okay, so the anti-HCV here is not protective. It's only a marker of exposure. Now, the important part of this slide also is that if you want to know if the patient has active infection with hepatitis C, you don't check for anti-HCV. The anti-HCV just tells you that you may have to check for another marker. So what is the marker that tells you that the patient has active infection? That will be your HCV RNA. So if your HCV RNA is positive, then the patient is infected with hepatitis C. Okay. Now there are, of course, unusual labs again. You can sometimes have a positive anti-HCV but negative HCV RNA. So what did we say about the anti-HCV? It's a marker of exposure, right? HCV RNA is a marker of infection, that the patient still has active infection with Hep C. Now in patients with acute hepatitis C, sometimes you can also have a transient decrease in your HCV RNA. So you can sometimes have a transient low-level viremia in acute hepatitis C. So the HCV RNA decreases to very low levels initially, but then sometimes if they uh, are going to proceed to chronic viral infection, then the HCV RNA becomes positive again. So that can happen in acute hep C. But it can also be because of resolution. So in patients with, it can be spontaneous in 15% of the time. So the patients may have a negative HCV RNA. Since we have mentioned that anti-HCV is a mark of exposure only, then the patient may still be, will still be anti-HCV positive. Now in patients with acute hep C, you may have to retest the HCV RNA 4 to 6 weeks after to recommend, to confirm resolution of the infection. Okay. Now, you can also have a negative anti-HCV but positive HCV RNA. This usually happens in patients with chronic hep C infection who happens to be immunosuppressed or immunocompromised. So if you are immunocompromised, you are not able to mount any antibodies. So even if you're infected, you have HCV RNA, the anti-HCV is negative. But in some cases, it can also be a false negative result. So the lab made a mistake, or in patients with very early acute infection. So if you look at the um, slide earlier, in patients with acute infection with resolution, the first marker that will be positive usually is your HCV RNA. And the HCV usually appears 8 to 10 weeks after only. Okay. So available treatments options in the Philippines. Well, if you look at your book, it still has a long discussion about PEG interferon treatment for hepatitis C. Nowadays, that will only be for historical context. I mean, nobody will ever use PEG interferon anymore for hepatitis C because before, if you look at the, if you have a lot of time in your hands, if you read through PEG interferon, you will see that the response rates there with PEG interferon are very low. Only about 50 to 60% of patients respond. Compared to the present, oral treatments, the response rates are more than 95%, um, even close to 99% response rates. Okay, so basically, if you want to be pangenotypic, meaning you don't even need to check for the genotype nowadays, then you use sofosbuvir plus velpatasvir. That will be the drug of choice. Daclatasvir can also be used, but usually it's velpatasvir plus sofosbuvir. Okay, so using these drugs nowadays, the chances of cure for hepatitis C are very low. Very high, more than 95, 99%. Okay. We're now down to the last virus, and that is hepatitis E. Now, if you look at the serology for hepatitis E, this is very similar to hepatitis A, where the initial antibody that you see is your IgM, and then once you resolve your hepatitis E virus, your IgG anti-HEV will now be positive. So that is a typical serology course, very similar to your hepatitis A. The main difference in terms of manifestation is that, as I've said, the chronic stage can occur in immunocompromised patients. And in pregnant patients, these are patients who are at risk to really have very severe forms of the infection. Okay, so that's just to summarize. These are the antibodies that I've mentioned, and I've put in this slide, what it means, what is the clinical implication of the antibodies, and what happens with these antibodies with resolution. Let's take, for example, hepatitis. Okay, what happens with hepatitis A? If you have IgM, what is the clinical implication? Then you have acute Hep A infection if you have IgM anti-HAV. What happens with resolution? The IgM disappears, but you now develop your IgG. Okay? What about with hepatitis B? Anti-HBs, clinical implication is that you're immune to hepatitis B, except if you have HBs antigen positivity as well. Okay? What happens with resolution? Anti-HBs is usually positive, and then anti-HBC is usually positive as well because you resolve the hepatitis B. You were exposed. Okay? Unlike in patients with vaccination, the anti-HBC should be negative, but you have anti-HBs. Okay? What about hepatitis C? So anti-HCV, as I mentioned, it's just a marker of exposure. It's not a marker of, it's not a protective antibody. Okay? So in patients with resolution, the anti-HCV is still positive. What about hepatitis D? For hepatitis D, um, IgM denotes acute hepatitis D. IgG denotes chronic hepatitis D, but in patients with resolution, it can still be positive, but will become slowly decline over time, and it will now become negative in patients with resolution. It's very similar to hepatitis A. Now, I've highlighted in green the antibodies that are protective. So only anti-HAV IgG, anti-HBs, and anti-HEV IgG are the protective antibodies. The rest are really not protective antibodies. They have different clinical implications as I've shown in this slide. Okay? So again, what are the markers of resolution? For hepatitis A, then you should have the IgG. And if you happen to check for it, your HAV RNA should also be negative. What about B? For B, your HBs antigen should be negative, okay? Because you resolve the infection. Then, ideally, the patient should now produce the protective antibody, the anti-HBs. And your DNA is usually undetectable in the serum, or sometimes you can have very low titer HBV DNA even if you already have resolved the infection. And this is because of your cccDNA. Okay? What about hepatitis C? Markers of resolution? HCV RNA. Okay? Hepatitis D. HDV RNA will be the marker of resolution, and then over time, your anti-HDV IgG should also disappear in patients with resolution of hepatitis D. Hepatitis E is very similar to hepatitis A. You will have resolution of your hepatitis E if you develop IgG anti-HEV. Okay. So just to review, I'll give you a few cases just to test your knowledge of the serology. So we have case number 1, an 18-year-old female nursing student with this with a positive HBs antigen. So the patient is S antigen positive, E antigen positive also, anti-HBA negative, ALT was normal, DNA was very high. Okay? Answer to this question: is the patient in the immune tolerant phase, immune clearance phase, inactive, or reactivation? The answer here, of course, is the patient is in the immune tolerant phase. Why? Because the ALT is normal, the DNA is high, the E antigen is positive. So these patients, in these patients, the immune system is tolerating the presence of the virus. There's no immune system destruction of the liver because the ALT is normal. The patient is in the immune tolerant phase. What about this patient? 40-year-old virgin macho dancer diagnosed with Hep B 10 years ago. The patient is still HBs antigen positive, but with anti-HBs. ALT is normal, E antigen is negative. So what will be your advice in this patient? I think I've stressed this enough. The answer, of course, here is that the patient's still positive, right? Because even if the S antigen, even if the patient already has anti-HBs, if the HBs antigen is positive, the patient is infected. No question asked. Okay? Patient still needs surveillance. What about this case? 24-year-old male with these labs. So we'll break this question down into three parts. One is your hepatitis B diagnosis. Will it be acute hepatitis B, chronic hepatitis B, or resolved hepatitis B? Again, S antigen is negative, anti-HBC positive IgG, anti-HBs positive. So what is your answer? Of course, it's resolved hepatitis B because primarily because of your S antigen, it's negative. Okay? What about the hepatitis C? Anti-HCV is positive, HCV RNA is positive. What will be your diagnosis? Is it acute? Is it chronic? Is it resolved hepatitis C? The answer here is really, we cannot be sure whether the patient has acute or chronic hep C, right? The only way to know if the patient has chronic hep C is that the HCV RNA should be positive for at least 6 months. But given the case, we will not know because we just have a snapshot in time of a patient who happens to have this serology. Okay, so we cannot really tell whether the patient has acute hep C or chronic hep C. But what are the clues that this patient probably, if you ask me, an educated guess is that patient probably has chronic hep C. Is that because the patient probably was exposed to hepatitis C as an adult? Because look at the hep B status. This is a patient probably with co-infection with hep C and hep B. The patient resolved the hep B but remained positive for hepatitis C. That is why I would say this patient probably has chronic hep C instead of acute hep C. Another thing is that usually for acute hep C, the ALT levels should be very, very high because as I've said earlier, if you have acute infection, the ALT is usually very, very high. What about the hep A diagnosis? IgM is negative, IgG is positive. I think you already know the answer here. The patient has immunity to hepatitis A, maybe from vaccination or maybe from exposure as a child. This is our final diagnosis. We have a patient with hepatitis C infection. We're not sure if it's acute or chronic, but most likely chronic, with resolved hep B and immunity to hepatitis A. Okay? So I think that